Okay, let's unpack this. We are undertaking a critical deep dive into the foundational principles of minimal access surgery, or MAS, as you'll hear it called. This is, well, arguably the most transformative area of surgery over the last 50 years.
It truly is, yeah. MAS isn't just, a set of techniques. It's really a whole surgical philosophy shift.
Our mission today is to give you a complete, structured understanding of this field, from its slightly quirky historical roots right up to the sharpest edge of robotic AI integration. So if you are reviewing this material for your rotations or perhaps for exams, we're aiming for maximum recall and hopefully some profound practical insight.
Exactly. We're targeting those core concepts you really need for a robust understanding and, crucially, for safe practice, trying to distill the entire picture.
So let's start with basics, the official definition. Minimal access surgery, it aims to accomplish therapeutic goals with minimal somatic and psychological trauma. It's about much more than just how the scar looks, isn't it?
Oh, absolutely. It's fundamentally about minimizing the wound trauma itself, reducing disfigurement, yes, but also enabling much, much faster patient recuperation.
And those results, well, they really drove adoption like crazy.
Exponentially. And when patients recover faster, you get this cascade of secondary benefits. It can be more cost-effective for health systems because of shorter hospital stays, and perhaps most importantly, especially in complex cases, the improved visualization and instrumentation can actually lead to, quantifiable increases in operative precision compared to traditional open approaches.
It's a key point. And the timeline is surprisingly long, isn't it? Our historical hook, it starts way back in 1901. George Kelling, who was a real pioneer, performed the first experimental laparoscopic procedure.
On a dog.
On a dog, yeah. Using a cystoscope, of all things, and air insufflation.
Just imagine that. Taking a tool designed for the bladder, sticking it in the abdomen, basically duct taping two ideas together. Then Jacobius followed up in 1910 with the first human thoracoscopy, also using a cystoscope. Wild.
It really is.
Yeah.
But the leap to what we think of as modern MAS needed a crucial piece of tech, right?
Video, absolutely. The real breakthrough didn't happen until 1987, when Philip Moret performed the first video laparoscopic cholecystectomy. That integration of the camera and the monitor, that's what really launched the widespread adoption we saw explode in the 1990s.
That journey from a cystoscope in 1901 to a full video system less than a century later, it's just staggering. And now, this approach is thoroughly multidisciplinary. It crosses every surgical specialty boundary.
Absolutely. The principles are universal, really. But the application, well, that requires different specific approaches depending on the body cavity or the plane we're trying to access.
Okay, so let's move into those different modalities. Because MAS isn't just one thing. It's a whole landscape of different approaches. When we talk about accessing cavities, the two most common are laparoscopy and thoracoscopy. Let's maybe nail down the technical distinctions there.
Sure. So laparoscopy is kind of the default minimal access approach for the abdomen. It involves introducing a rigid endoscope, a camera, through a small port into the peritoneal cavity.
Right.
The key mechanical thing here is the mandatory use of pneumoperitoneum, that's gas insufflation, usually CO2, to lift the flexible abdominal wall away from the organs, the viscera, and create a working space. Without that gas, you can't see or do anything safely.
And what about thoracoscopy, or VATS, video-assisted thoracoscopic surgery? How's that different?
VATS is similar in that you introduce a rigid endoscope through an incision, but this time it's between the ribs to get into the thoracic cavity. The key difference from laparoscopy, though, is that in the vast majority of cases, you don't need gas insufflation.
Oh, okay. Why not?
Because the rib cage is rigid. It naturally maintains the working space. Unlike the abdomen, which is floppy, the chest holds its own shape.
So the logistics are fundamentally different then?
They are. Although I should say, for certain specific procedures like operating on mediastinal tumors or maybe diaphragmatic surgery, you might use low-pressure gas insufflation, typically just 5 to 8 millimeters of mercury, maybe briefly, just for better visualization or perhaps hemostasis.
Okay.
But the critical logistical difference, the one you really need specialist support for, is the anesthetic side. VATS procedures nearly always require single lung ventilation.
Right, collapsing one lung.
Exactly, which means using specialized double-lumen endotracheal tubes to isolate the lung you're operating on. You let it collapse slightly to give you space, while the other lung keeps the patient oxygenated. That needs expert anesthetic management.
That's a significant requirement, isn't it? A higher level of anesthetic involvement compared to, say, standard laparoscopy.
Okay, now let's look at the concept designed to push the minimal access idea right to its limit. SILS, or single incision minimal access surgery.
Right, SILS. This is really part of that continuous drive to reduce the total number of wounds. The idea is that all your instruments go in through a single multi-channel port.
One hole.
One hole, yeah. Typically placed at the umbilicus, the belly button, because, well, we have a natural scar there anyway.
The cosmetic benefit for patients must be pretty significant with SIs.
It often is, yeah.
Ah,
It's frequently described as virtually scarless. And the advocates also point to potentially reduced postoperative pain, maybe fewer chances of port site bleeding, and perhaps a lower risk of port site hernia, simply because you only have one hole in the fascia instead of 3 or 4.
but it's not the default for everything, which tells me there must be some significant drawbacks. What are the main concerns from the skeptics?
Yeah, the main concerns are really technical and financial. First, the procedural difficulty is significantly higher. Imagine trying to work with multiple instruments all coming through one tiny entry point, all parallel to each other.
Like knitting through a keyhole.
Kind of. You get instrument clashes, what surgeons call sword fighting inside the patient, and it really limits your ability to triangulate, to get good angles for dissection and suturing. This translates to a very steep, very specialized learning curve. Okay, so it's hard to do. What else?
Second is the cost. These special multi-channel ports and the often complex articulating instruments needed for OLIGAs are expensive. Plus, the longer operating room time, especially during that steep learning curve, might not be offset by really clear, quantifiable clinical benefits compared to a well-executed modern multi-port technique.
Right, so you're trading increased complexity, cost, and potentially longer or R time for maybe a better cosmetic result, but possibly without a big improvement in actual clinical recovery.
That's the debate, precisely. And we see a similar sort of thing in thoracic surgery with uniportal VATS. While it's suitable for some minor procedures, doing complex resections through one port often remains technically harder and slower compared to using multiple ports.
Okay. Moving away from poking holes in the body wall, we have approaches that use existing pathways. Let's talk about endoluminal and natural orifice surgery, or NOTES.
Right. Endoluminal surgery is where you use flexible or sometimes rigid endoscopes introduced into hollow organs and systems. Think the GI tract, the urinary system, the airways, even blood vessels.
Like standard endoscopy, maybe more advanced.
Exactly. It allows surgeons to manage quite complex pathology, like performing an endoscopic submucosal resection of an advanced polyp in the colon, or maybe an endobronchial laser resection of a tumor in the airway without ever making a skin incision.
And NOTES, natural orifice transluminal endoscopic surgery. That sounded like the ultimate scar-free future for a while.
It did. NOTES was this really ambitious idea to perform major abdominal operations, like taking out a gallbladder or an appendix, entirely through natural orifices. So going transgastric through the stomach wall or transcolonic through the colon wall into the peritoneal cavity.
So why hasn't NOTES taken off if the promise was so huge? It sounds amazing.
Well, the primary safety concern, the big hurdle, remains the difficulty in achieving a really reliable, safe closure of that visceral puncture site.
The hole you made in the stomach or colon.
Exactly. The point where the endoscope crosses from the lumen into the peritoneal cavity. If that closure fails, you risk leakage, peritonitis, potentially catastrophic complications. And the current technology and techniques just make reliably closing that hole quite problematic. Add to that the high training burden and device costs, and it's really limited its clinical uptake so far.
Okay. We also have surgery performed outside the main cavities, right? Using paravisceral and extraperitoneal approaches.
Yes, this is about accessing body planes and spaces without actually entering the peritoneal cavity or the pleural space.
Right.
Good examples are retroperitoneoscopy for getting at the adrenal glands or kidneys or the aorta from behind the peritoneum, or mediastinoscopy for accessing lymph nodes in the chest, which has actually been around since 1959.
And what's the major advantage of staying out of the peritoneum, for instance?
It can radically reduce morbidity in certain situations. By avoiding handling the bowel and the visceral peritoneum, you reduce the risk of developing internal adhesions later on, you reduce the risk of ileus, that slowing of the gut, and potentially bowel injury. So this approach is really effective for things like certain types of hernia repair, or maybe endoscopic saphenous vein harvesting for cardiac bypass surgery.
And the tools have improved for this, too.
Definitely. Novel videoscopes now give you fantastic visualization, even in these quite tight potential spaces, which improves both safety and accuracy significantly.
Okay, finally in this section, let's touch on blending techniques. Hybrid minimal access surgery. This sounds like an admission that pure MAS isn't always the perfect tool for the job.
That's often true, yeah. Sometimes the best approach is a mix. Hybrid techniques can be totally endoscopic, like combining an endoluminal scope, say, in the bile duct, with an extraluminal scope, the laparoscope, outside it. That's great for complex gallstone disease or maybe tricky colonic polyps.
Or you can mix open and endoscopic.
Right, and that's what we call HALS, hand-assisted laparoscopic surgery.
Hand-assisted. So describe that. How does that work physically?
HALS involves making a small mini-laparotomy incision, usually just big enough to get the surgeon's hand or maybe part of their forearm inside the abdomen. But crucially, you maintain the pneumoperitoneum, the gas bubble, using a specialized sealed port that the hand goes through. So you have gas, cameras, instruments, and a hand inside.
Okay, but why put the hand back in if the whole point of MAS is small incisions?
Yeah.
What can the hand do that instruments can't?
Several really critical things. Manual palpation, actually feeling a tumor to assess its texture or extent, which is impossible with 2D vision and very difficult even with robotics. Gentle, blunt dissection using your fingers, which can be much more nuanced than metal instruments. Retracting heavy organs safely. And maybe most importantly for safety, direct finger pressure on a bleeding vessel while the instrument team works to get proximal control. That can be life-saving.
I can see the utility, especially for safety and maybe efficiency in tough spots. But doesn't putting a hand in negate some of the MAS benefits?
It does negate some, yes, but not entirely, especially if the specimen you need to remove, say, a large piece of colon would require a similar-sized mini-laparotomy incision for safe extraction anyway.
Right. If you need the hole anyway.
Exactly. And for surgeons who trained primarily in open techniques, HALS is often seen as a valuable bridge. It can feel safer and easier to learn than jumping straight to a purely laparoscopic approach for complex cases. Having said that, as new generations of surgeons train fully laparoscopically from the start, the use of HALS is expected to diminish. It'll probably remain important for only the most challenging or maybe high-risk conversion scenarios.
That sets the stage perfectly. Now, we really need to define the trauma baseline we're comparing against.
Yeah.
Let's just remind ourselves why traditional open surgery, the historical standard, is considered so traumatic.
Right. The vast majority of the trauma in open surgery comes simply from the need for a large wound. The surgeon needs that big opening just to get adequate exposure, to see and safely access the deep surgical field.
And that big wound itself generates a whole cascade of potential problems or morbidity.
Precisely. You have the wound morbidity itself, things like infection, dehiscence where it breaks down, bleeding, chronic pain from nerve entrapment, and later on, incisional herniation. But it's not just the wound. Internally, the significant pain limits the patient's mobility.
Which has knock-on effects.
Big time. That reluctance to move and breathe deeply contributes significantly to pulmonary problems like atelectasis or collapsed lung segments, chest infections, ileus where the gut slows down, and even DVT, deep vein thrombosis from immobility.
Plus, we have to account for the trauma caused by the retractors and just being open to the air.
Yes, absolutely. Those big metal mechanical retractors or even human assistants holding retractors for hours cause localized pressure damage, sometimes nerve injury. Contrast that with laparoscopy, where the retraction is mostly provided by the gentle diffuse pressure of the gas, the pneumoperitoneum, against the body wall. And then there's the exposure itself being open to the atmosphere causes significant morbidity through cooling the patient down and fluid loss via evaporation. MAS dramatically reduces both of those.
So we summarize the MAS advantages, the goals of this whole philosophy we're looking at: decreased wound size and all the complications that come with that, reduced pain, therefore improved mobility, less heat loss, and often critically improved visualization thanks to those HD cameras right up close.
Yeah, those outcomes are so compelling that MAS is no longer just for planned elective cases. We're seeing its widespread adoption in emergency surgery, too. Things like putting an omental patch over a perforated peptic ulcer laparoscopically, or washing out localized diverticulitis, even doing the initial assessment for trauma in patients who are hemodynamically stable.
But the small cuts aren't a magic bullet. There are trade-offs. The core technical limitations of what we might call straight-stick MAS, the non-robotic kind, are really what have driven the constant innovation, particularly pushing towards robotics. So let's dive into those limitations.
Okay. The foundational limitation, the one that impacts everything else, stems from the visual system. It's the lack of true three-dimensional vision in standard 2D endoscopy. The camera, the endoscope, delivers a flat two-dimensional image of a three-dimensional space.
Which immediately puts a massive
Yeah.
cognitive load on the surgeon, right? All those visual cues we rely on subconsciously in open shadows perspective, how things relate in space, they're just gone. You're navigating a completely new, flat anatomical landscape.
That's exactly right. It forces the surgeon to learn and rely on monocular depth cues, things like relative size, light and shadow, parallax motion, and it really exacerbates hand-eye coordination challenges. This is why there's such a notoriously steep learning curve for basic laparoscopic skills.
Now, you mentioned 3D imaging systems are available, but they haven't completely taken over. Why not? Even setting aside the cost.
Well, the technology isn't quite seamless yet, or at least it has been historically. Some of the earlier commercial 3D systems were linked to significant ergonomic problems for the surgeon, things like headaches, eye strain, visual fatigue, and often this was without a really clear, measurable increase in objective accuracy or speed for the tasks being performed that justified the hassle.
Hmm.
Plus, they often reduce the brightness of the display and usually require specialized viewing glasses, which can introduce issues with sterility, fogging, and just general comfort during long operations. This is one big reason the industry really pushed towards robotic systems that could build inherent passive 3D viewing right into the console.
Okay, limitation number 2, operational speed. MAS can often be technically slower and more demanding, especially complex procedures.
And this is a critical safety consideration. Prolonged operative time, and therefore prolonged anesthetic time, can start to eat away at the benefits of the minimal approach. It increases the risk of complications like respiratory issues, wound infection, nerve damage from positioning, compression neuropathy, and VTE. Which brings us back to that absolutely vital safety principle.
Say it again.
Conversion to an open operation should never be viewed as a failure or a complication. It is usually the result of sound surgical judgment, prioritizing patient safety above everything else. Knowing when to convert is a key skill.
Absolutely. Okay, what about just controlling the view, especially when things go wrong? This leads us to the difficulty in achieving hemostasis, stopping bleeding.
Yeah, bleeding. It remains the single most common reason for converting from MAS to open surgery. When blood enters the field, it messes up the view significantly.
Yep.
Because blood absorbs the light from the endoscope's tip. It makes everything dark and murky, dramatically reducing image quality just when you need it most. Safe management requires a very experienced camera assistant who can constantly clean the lens and optimize the visual field, and crucially, it requires the surgeon to have a low threshold for converting early if controlling the bleeding is proving difficult. If the situation spirals out of control, well then all the initial benefits of the minimal access approach just vanish.
Right. The third major limitation hits right at the heart of surgical intuition, the loss of tactile feedback. Surgeons lose that ability to feel tissue density, to tell tumor from normal tissue by touch, or to identify a pulsating artery hidden just beneath some fat.
This loss of sensation is fundamental. It's a huge difference from open surgery. And while there's ongoing research into things like complex haptic gloves and biofeedback systems, currently, we mainly rely on visualization substitutes to try and bridge that gap.
And the main substitute is?
Laparoscopic ultrasonography, or laparoscopic US. It's the most powerful substitute we have right now. It essentially gives you a high-resolution visual appraisal of structures that you would otherwise need to palpate. It allows surgeons to accurately stage nodal disease in cancer surgery, for example, or explore the bile duct for hidden stones. It effectively replaces the sense of touch with detailed visual data.
Okay. Then there's the very practical issue of getting the specimen out. If the surgery is minimal access, but you've just removed a large chunk of organ, you still need a pretty big hole to remove it, don't you?
Precisely. Removing a segment of lung or a large piece of colon or a kidney still requires significantly enlarging one of the port site incisions, which inevitably negates some of the cosmetic and pain advantages of the MAS approach.
And there are rules about how you handle specimens, particularly in cancer cases.
A critical rule: you absolutely cannot use morcellators devices that mince up the tissue on malignant specimens. Doing so completely disrupts the gross specimen morphology and makes accurate pathological staging impossible, which compromises patient care. So, big specimens have to come out intact.
Which means the goal then shifts to finding the least traumatic extraction route possible.
Exactly. Various techniques are used, removing large lung specimens via the subxiphoid approach below the sternum to avoid spreading tumor cells in the chest wall or damaging intercostal nerves, or sometimes attempting natural orifice extraction for abdominal specimens, for example, carefully pulling a resected piece of colon out through the anus or the vagina. However, these alternative routes introduce their own specific potential complications, like a higher risk of hernia at that extraction site, or maybe localized injury outside the main operative field.
Right. Finally, let's talk cost.
Yeah.
Is MES still inherently much more expensive than open surgery?
For the standard straight-stick laparoscopy and thoracoscopy, the cost gap has narrowed significantly over the years. While the disposable consumables, the ports, trocars, specialized energy devices, staplers are definitely more expensive than reusable open instruments, the high volume of these procedures now, combined with the proven improved outcomes and radically shorter hospital stays in many cases, means that overall, standard MAS has become pretty cost-effective for healthcare systems.
But the calculation changes when we move to the next level of tech.
It does. The economics definitely shift again when we start talking about the next generation of pathology, which brings us squarely into the realm of robotics.
Right, robotics, which seems clearly engineered to tackle those core limitations of straight-stick MAS we just discussed, particularly the 2D vision and the restricted instrument movement. Before we get into the specific systems, how do we even define a surgical robot? What is it?
Fundamentally, a surgical robot is a mechanical device that executes automated physical tasks. Now, that execution might be under direct, real-time human supervision, like the systems we mostly use now, or it could be following pre-programmed guidelines or potentially even integrating artificial intelligence. It essentially creates a very advanced human-machine interface for performing surgery.
Okay. And we generally break these systems down into two main functional categories.
Broadly, yes. First, you have the teleoperated or master-slave systems. This is the dominant type in general surgery today. Here, the surgeon sits, often physically remote from the operating table, at a console that's a master, and controls the movements of the robotic instruments, the slave, which are positioned over the patient. This setup is what establishes the technical potential for remote surgery, although that's still rarely performed in practice. It has been done.
Okay, master-slave. And the second category involves more machine autonomy.
Right. These are active or semi-active systems. They're usually image-guided or pre-programmed to perform specific tasks. Active systems can execute a pre-programmed task with very high precision. A classic example is the rogo-DOC system, which was designed for preparing the precise femoral cavity in hip replacement surgery. Semi-active systems are more about assisting the surgeon, maybe by stabilizing instruments against tremor or providing tracking guidance along a planned path.
Got it. Let's maybe hit some high points in the history of surgical robotics, because it's a fascinating story of iterative development. Where did it really begin in a clinical setting?
Well, the first documented clinical robotic procedure was actually in neurosurgery, way back in 1985. They used the PMA 560 robot, which was an industrial arm, for a CT-guided brain biopsy. Then came the EASOP system in 1992. Yeah, automated endoscopic system for optimal positioning. It was actually a relatively simple but incredibly useful device, essentially a voice-controlled camera arm. It freed up the human assistant who would normally have to hold the laparoscope steady for hours, letting them do more useful things. It became pretty ubiquitous.
Right. And the system that really paved the way for the modern teleoperation systems we see now.
That would arguably be the Zezios robot, which was launched around 1996. ZUS was a true master-slave system. It offered key advancements like motion scaling, where large hand movements are scaled down to tiny instrument movements and tremor correction.
And ZUS achieved some major firsts, didn't it?
It did. It was used in 1998 for the first fully endoscopic robotic procedure, which was a fallopian tube reanastomosis. And then, perhaps more famously, in 2001, it was used for the first transatlantic remote surgery, the Lindbergh operation. A surgeon in New York performed a cholecystectomy, a gallbladder removal, on a patient located in Strasbourg, France. That really proved the fundamental concept of telepresence surgery was viable.
An incredible proof of concept. And that led more or less directly to the system that dominates the market today.
The Da Vinci surgical system from Intuitive Surgical, yeah. It received FDA approval for clinical use in 2000. And the subsequent versions, the Da Vinci S, then the Psi, and now the current Xi platform, have really cemented its market dominance over the last 2 decades.
What gives the Da Vinci its edge? Why did it win out over systems like ZUS?
It really comes down to how effectively it addressed those core limitations of traditional MAS we talked about. It integrates high-definition 3D vision right into the surgeon's console. It features the crucial endo-wristy instruments, which provide articulation far beyond human wrist capability. And it incorporates refined motion scaling and tremor reduction algorithms.
And the Da Vinci SP, the single port system, that seems like the ultimate expression of trying to minimize access trauma.
It's certainly the latest evolution, focusing specifically on reducing the access trauma even further. The SP system manages to deliver multi-jointed, wristed instruments and a wristed camera, all through a single small entry point, maybe 2.5 centimeters. This allows for true operative triangulation and dexterity inside the patient, even though all the tools originate from the same tiny hole, further minimizing that fascial defect.
Okay, let's really break down the specific advantages robotics offers, starting with vision.
Yeah.
You said it solved the 2D problem.
Instantly. The Da Vinci Vision System provides true 3D, high-definition, stereoscopic images directly to the surgeon at the console. This gives the surgeon genuine depth perception, completely eliminating that need to mentally reconstruct the 3D space from flat 2D cues. It makes the operative field immediately intuitive and relatable, much more like open surgery in that respect. Plus, the wristed cameras, especially in the SP systems, can articulate and look around corners, allowing you to triangulate the field of view in ways that fixed-angle straight sticks simply cannot.
And the maneuverability. The instruments themselves are just a world away from stiff laparoscopic tools.
Absolutely. The endowristy instruments provide up to 7 degrees of freedom of motion. They can bend, articulate, and rotate in ways that mimic, and in some aspects actually exceed, the dexterity of the human hand and wrist. This is absolutely invaluable in confined operative spaces. Think deep in the pelvis during rectal cancer surgery, or maybe transoral robotic surgery in the throat areas where conventional MAS is severely limited by the stiffness and lack of articulation of the instruments.
And the mechanical advantages, motion scaling and tremor suppression, that sounds almost like giving the surgeon superpowers.
It's a core safety and precision feature. Large, natural hand movements made by the surgeon at the console are scaled down by the computer into extremely precise millimeter-scale movements by the instrument tips inside the patient. And crucially, the system actively filters out even the natural physiological tremor that everyone has in their hands. This allows for unprecedented stability and micro-precision, especially during delicate dissection or suturing.
We touched on ergonomics earlier, but it's worth stressing again, particularly for those really long, complex cases, say, a major cancer operation or a complex bariatric procedure.
The ergonomic advantage is profound. The surgeon is seated comfortably at a console, looking down into the 3D display with their arms naturally supported. This drastically reduces the physical strain, the muscle tension in the back and shoulders, and the overall fatigue that's often associated with standing, sometimes awkwardly, over a patient for many hours during a conventional laparoscopic case.
But there's a flip side to that comfort.
There is. That physical separation from the patient and the bedside team means you lose a lot of the nonverbal communication cues. The surgeon at the console can't easily see what the assistant is doing or anticipate their needs visually. This necessitates extremely strict, clear, explicit verbal communication protocols within the team. Everyone needs to talk through every step.
Okay. Now, despite these pretty clear advantages, robotics still faces that big hurdle, cost. Just how high are the barriers to entry?
They remain substantial. Robotic systems carry very high capital acquisition costs, millions of dollars, and significantly higher per procedure costs due to the expensive, oft unproprietary, disposable instruments and drapes compared to conventional MAS. While the improved ergonomics might lead to fewer surgeon-related fatigue errors, and maybe some procedures are enabled that weren't feasible laparoscopically, demonstrating a clear, uniform improvement in patient outcomes or length of stay across the board that justifies that massive investment remains challenging in many surgical specialties.
So institutions often try to offset that huge capital cost by sharing the robot across multiple surgical departments, general surgery, urology, gynecology, cardiothoracics. How does that impact the individual surgeon trying to get proficient?
Well, it creates a bit of a training and access conundrum. While the hospital gets more bang for its buck by maximizing the robot's utilization, the reduced individual access time for any single surgeon can significantly prolong their learning curve. It makes it harder to get enough cases under their belt quickly to achieve and then maintain proficiency, especially for complex procedures.
This cost pressure and the desire for alternatives has finally started to crack open the market, right?
Yep.
New competitors are emerging, trying to disrupt that Da Vinci dominance. What are these new players focusing on?
Primarily, they seem to be focusing on modularity and cost reduction. Interestingly, Intuitive itself responded to this pressure with the DaVinci X model, which is marketed as a lower-cost entry point to their ecosystem, maybe with slightly fewer bells and whistles than the flagship GG.
What about completely new systems?
Right, you have systems like the RVO-I from Korea, which uses a forearm design mounted on a single mobile cart and provides 3D HD vision via glasses similar to some laparoscopic setups.
And the Versius system from CMR Surgical in the UK,
Mhm.
their approach seems quite different, more modular.
That's their key differentiator, yeah. Versius uses individual cart-mounted robotic arms. Each arm is designed to mimic the articulation and range of motion of a human arm more closely than the sort of over-the-patient structure of the Da Vinci. This modularity is intended to give the surgical team much greater flexibility in positioning the arms around the operating table, potentially improving port placement freedom and making the system maybe easier to integrate into different types of operating theaters without major modifications.
And then there's the Senhance system, which I remember hearing about specifically tackling the expensive consumables problem.
Absolutely. The Senhance system, originally developed by Transenterix, takes a different approach. It uses standard, reusable, non-wristed laparoscopic instruments that are simply docked into the robotic arms. This aims to significantly lower the cost per procedure by avoiding those expensive proprietary disposable wristed instruments. It still offers features like 3D HD vision and eye tracking camera control, sort of trying to bridge the familiarity and lower cost of straight stick techniques with some of the stability and visual benefits of robotics.
So the competition is heating up.
Definitely, including the upcoming Hugo system from Medtronic as well. The universal themes seem to be trying to lower those recurring costs and increase the flexibility and modularity of the systems. It's a space to watch.
Okay, Section 4. This is absolutely vital for anyone actually practicing or learning this material. The practical application, the nuts and bolts of safety and logistics in MAS. Let's start right at the beginning. Preoperative patient preparation. What's the essential checklist for deciding if a patient is fit for MAS?
Right. The absolute key is that a patient must be fit not only for general anesthesia, but critically, they must also be deemed fit enough to withstand an open conversion if that becomes necessary during the procedure. You can't plan an MAS case assuming it will definitely stay MAS.
So you need to meticulously assess their overall health, their comorbidities.
Absolutely. Patients with severe respiratory disease like really bad COPD or significant ischemic heart disease might be poor candidates for long MAS procedures, especially laparoscopy. The physiological stresses of the CO2 insufflation, the pneumoperitoneum, puts extra strain on both respiratory and cardiac function. You have to be confident they can tolerate that, potentially for several hours, and tolerate an open operation if needed.
What specific things in a patient's history really flag up a potentially high risk in minimal access surgery?
Well, a history of coagulation disorders, bleeding problems is profoundly dangerous. Your options for achieving rapid, effective hemostasis internally are generally more constrained and technically demanding laparoscopically than they are in open surgery where you can get direct pressure and access.
And previous surgery.
Crucial. Previous extensive abdominal surgery or maybe prior oncological treatment with radiation likely means significant internal adhesions, scar tissue. That creates a really hostile and potentially dangerous environment for that initial blind trocar placement. You have to anticipate difficulty and plan your entry strategy very carefully.
Which leads to the idea that the pre-op checklist must include setting a clear threshold for conversion.
That is absolutely non-negotiable. The surgeon must think about it beforehand, define it, and ideally communicate it to the team and perhaps even the patient in broad terms before starting. What specific conditions, maybe uncontrolled bleeding, maybe inability to progress safely, maybe just excessive operative time will trigger an immediate decision to convert to open surgery. Having that threshold defined removes hesitation in a critical moment.
We also need to think about the patient's body shape, their habitus.
Yes. Moderate obesity is generally manageable these days, but morbid obesity often requires specialist instrumentation, things like longer trocars and instruments to reach, and potentially specialized operating tables that can handle the weight and assist with extreme positioning if needed. Conversely, a patient with a very low BMI, very thin, or just a small physical frame can sometimes make positioning challenging, especially fitting around the large robotic arms.
Thromboprophylaxis preventing blood clots seems particularly paramount due to the positioning often required in MAS.
Exactly. Many MAS cases, especially prolonged laparoscopic procedures in the pelvis or upper abdomen, require the patient to be in steep Trendelenburg, head down, or reverse Trendelenburg head-up positions for long periods. This significantly increases the risk of venous thromboembolism, VTE. So routine use of prophylactic measures like subcutaneous low molecular weight heparin injections before surgery, wearing anti-thromboembolic stockings, and using pneumatic calf compression devices during the procedure itself is absolutely essential for almost all major MAS cases.
And the informed consent process needs to be really specific, doesn't it? Addressing the technology and that possibility of conversion.
It absolutely does. The patient needs to understand the exact procedure planned, the specific risks associated with the MAS approach being used, like potential bowel or vessel injury during trocar insertion, gas embolism, etc., and what the alternatives are, including open surgery. They need to be reassured about the technology, especially if robotics is involved, address any anxieties they might have, and they must explicitly understand that conversion to open surgery is always a possibility and is done for their safety.
And you should probably warn them about common, less serious side effects, too.
Definitely. Things like the expected shoulder tip pain from diaphragmatic irritation or maybe minor surgical emphysema, gas trapped under the skin, should be mentioned preoperatively. They're usually harmless but can be alarming if unexpected, so warning patients helps prevent unnecessary anxiety post-op.
Okay, moving into the operating theater itself. How has the physical setup had to change to accommodate modern MAS and robotics?
Modern ORRs need to be highly flexible and tech-heavy. This typically means things like ceiling-mounted movable booms for monitors and equipment, multiple large high-resolution 4K monitors so the whole team can see clearly, a reliable piped CO2 supply with backup tanks, and integrated audiovisual equipment for recording, teaching, maybe even remote consultation.
And the team dynamic is critical.
Absolutely crucial, especially in robotics. The entire team, surgeon, assistant, scrub nurse, anesthetist, circulating nurse, must function as a really well-oiled unit. Because the surgeon at the console is physically removed, those strict verbal communication protocols we mentioned have to substitute for glances and nonverbal cues. Every team member needs to know their role inside out, and crucially, they need rehearsed protocols for both a planned, controlled conversion and an urgent, uncontrolled emergency conversion. Practice drills for undocking the robot quickly are essential.
Let's talk about that very first step, inserting the trocars, the ports. This can be one of the most hazardous moments, right? Especially in patients who've had surgery before.
It is potentially the moment of highest risk for inadvertently injuring bowel or major blood vessels that might be stuck, adhered, right underneath the entry point from previous surgery. So that preoperative assessment of existing scars is non-negotiable. For any patient with prior significant abdominal surgery, the safest technique for initial entry is usually an open approach, like the Hassan technique.
Describe the Hassan technique briefly.
It involves making a small skin incision, then carefully dissecting down through the layers under direct vision until you actually see the peritoneum, the lining of the abdominal cavity. You make a small hole in that undervision, insert a blunt-tipped trocar, and secure it with sutures. It avoids that initial blind puncture that causes most major entry injuries. Alternatively, some surgeons might make the fascial incision and then introduce a fingertip gently into the cavity first to feel for and sweep away any adhesions right at the entry site before putting the port in.
Okay, now let's tackle the most challenging intraoperative problem: bleeding. We established it's the most common reason for conversion. How do we approach managing it? Say, if you can actually see the specific vessel that's bleeding versus more diffuse, unidentified bleeding.
The absolute first step, regardless, is immediate, clear communication to the entire team. Let the anesthetist know, let the scrub nurse know, let the room know you have significant bleeding. This gets everyone prepared, gets more suction ready, maybe alerts the blood bank. The threshold for deciding to convert must be low and acted upon early if control isn't achieved quickly.
Okay, but assuming you try to control it minimally first, if you see the vessel.
If the bleeding vessel is clearly identified, then your standard MAS hemostasis techniques come into play. Applying clips, using endoscopic staplers, or employing advanced bipolar or ultrasonic energy devices to seal the vessel. Endoscopic suturing is also an option, but it's technically demanding, requires significant skill, and is often slower than other methods, which might be critical if the bleeding is brisk.
And if the source isn't clear, say if there's rapid bleeding that's just obscuring the field, what's the sequence then?
Right, that's a much scarier situation. First, immediate compression. Use a blunt instrument, a folded sponge on a stick, a pusher, or even gently compress the area with an adjacent organ if possible, just to tamponade the bleeding and allow you to stabilize the field for a moment. Second, Aggressive but careful suction and irrigation to try and clear the view.
And the third step is crucial.
The third step is the critical safety step. You must then gradually release that pressure, very slowly, while meticulously observing the area under maximum illumination and continuous irrigation, trying to pinpoint the exact origin of the bleed as the pressure comes off. Without that slow, controlled release, you've only bought yourself a temporary pause, and you'll lose control again the moment you fully remove the compression. You have to identify the source to treat it.
And if this happens during a robotic case, the conversion protocol is inherently more complicated because of the bulky equipment.
Significantly more complex and stressful. The entire bedside team must be drilled and confident in the process of urgent undocking of the robotic arms. This requires coordinated action under immense pressure. One critical advanced maneuver that can sometimes be employed is to deliberately leave one robotic arm, perhaps the one providing compression or maybe an assistance laparoscopic port, in place maintaining pressure on the bleeding site while the main surgeon breaks sterility at the console, scrubs back in quickly at the bedside, and starts the open conversion. It buys precious time.
What about bleeding specifically from one of the trocar sites itself? Say you nick the inferior epigastric artery putting a port in, or an intercostal artery during VATS.
That demands definitive control, often externally. Just applying localized diathermy or simple pressure inside often isn't enough for arterial bleeding at the port site. The gold standard technique for controlling significant arterial bleeding here is often the figure-of-8 suture maneuver.
How does that work?
You usually need to extend the skin incision slightly around the bleeding port site. Then, using a strong suture on a curved needle, you place 2 deep figure-of-8 stitches that pass through all layers of the abdominal or chest wall, going well above and well below the presumed track of the vessel. When you tie these down tightly, they effectively mass ligate the bleeding vessel, achieving both proximal and distal control. It's usually very effective and relatively quick to perform.
Is there a quicker safety alternative if the bleeding is really torrential and you can't easily place those sutures?
Yes, a useful temporizing measure is to use a Foley balloon catheter. You take a standard urinary catheter, insert it through the bleeding trocar site into the abdominal or thoracic cavity, inflate the balloon with saline maybe 10-20 milliliters, and then gently pull back on the catheter, applying traction. You can secure it externally under tension with a clamp. This pulls the inflated balloon up against the inside of the body wall, applying direct tamponade pressure to the bleeding vessel. It can be surprisingly effective and can be left in place for hours, even up to 24 hours, while the patient is stabilized or definitive repair is planned.
Okay, one last intraoperative problem. Dealing with blood clots. You mentioned standard suction can sometimes make things worse.
It can, paradoxically. Because laparoscopy relies on that CO2 gas insufflation to maintain the working space, aggressive, continuous suction can rapidly deplete the gas bubble, causing the cavity to collapse and making visualization even harder. So, suction needs to be applied judiciously, ideally, keeping the suction tip below the level of pooled fluid or using very short controlled bursts.
So how do you get big clots out effectively?
For removing larger, more solid clots, specialized rolled gauze swabs or surgical sponges, sometimes called cigars or lap sponges, are remarkably effective. You can carefully insert these through a larger port, typically a 12mm or a 15mm port, with the valve cap temporarily removed, use them to mop up the clot, and then remove them. This avoids aggressive suction and helps maintain the pneumoperitoneum. Of course, you need to be extremely careful when removing the port cap to minimize CO2 loss.
Let's wrap up this safety section talking about electrosurgery principles. Those inadvertent electrosurgical burns or injuries are terrifying because they often go completely unrecognized at the time of surgery.
They are deeply concerning, yes. The estimated incidence is maybe around 1 to 2 cases per 1,000 operations when using monopolar diaphragmy. And these injuries can occur through several different mechanisms, things like direct coupling, where current arcs from the active electrode to another nearby metal instrument, insulation failure, where cracks in the instrument's insulation sheath allow current to leak out and burn adjacent tissue, direct sparking to tissue outside the intended target, or even current passing through an unexpected path from one electrically isolated piece of tissue to another.
So what's the critical safety recommendation here? What's preferred?
The fundamental recommendation is that bipolar diathermy is inherently safer for most dissecting and coagulating tasks in MAS. This is because the electrical current path is highly localized, passing only between the 2 closely spaced tips of the bipolar instrument itself. This minimizes the risk of current spreading to unintended remote tissues. So bipolar should generally be preferred, especially when working in anatomically crowded areas or near vital structures.
But monopolar is still used sometimes.
It is, often for cutting or for broad surface coagulation. If monopolar diathermy is used, the surgeon absolutely requires a perfect, clear visual image of the instrument tip and the target tissue, must avoid using excessively high power settings, and crucially, must pay meticulous attention to the integrity of the instrument's insulation sheath before and during insertion. Check for cracks. Any suspicion of insulation failure means the instrument should be removed and replaced immediately.
Okay, moving into the payoff section. The typically rapid patient recovery after MAS. Postoperative care is generally much more straightforward compared to open surgery, thanks to that minimal trauma. But what's the absolute cardinal warning sign post-op, the thing that should make you immediately call for senior review?
It's the patient who develops a fever, becomes tachycardic, has a fast heart rate, or complains of severe pain that seems completely disproportionate to the size of the external wounds. Those signs, especially in combination, should always raise suspicion of a potential intra-abdominal complication like a leak, a bleed, or an unrecognized injury until proven otherwise. It demands urgent senior assessment and likely further investigation, maybe imaging. Don't ignore disproportionate pain.
Got it. A very common, though less serious side effect is nausea and vomiting.
Yes, postoperative nausea and vomiting, or PONV, is highly prevalent after general anesthesia and especially laparoscopy, affecting maybe up to 50% of patients to some degree. Thankfully, it typically responds well to standard antiemetic drugs like ondansetron. A key strategy here, though, ties back to pain management. We really need to rationalize or ideally avoid opiate analgesics whenever possible.
Why specifically opiates?
Because opiates are notorious for causing or significantly worsening nausea and also for impairing gut motility, potentially leading to ileus. So minimizing opiate use is a win-win for patient comfort and faster gut recovery.
Right. And every MAS patient, particularly after laparoscopy, absolutely must be warned beforehand about that infamous shoulder tip pain. It often confuses them. They think they've hurt their shoulder.
They really do. You have to explain clearly pre-op that this is referred pain. It originates from irritation of the diaphragm, usually by residual CO2 gas trapped underneath it, which irritates the phrenic nerve. That nerve shares pathways with nerves supplying the shoulder tip area. It is not a local shoulder injury. Reassure them it's common, expected, and typically settles within 2 to 3 days with simple analgesia like paracetamol or NSAIDs.
So, given the desire to avoid opiates, what is the general analgesic goal after most MAS procedures?
For most non-resectional abdominal MAS, like gallbladder surgery or hernia repair, the goal should be to manage pain primarily with non-steroidal anti-inflammatory drugs and NSAIDs, if appropriate for the patient, and regular paracetamol, acetaminophen. Opiates should really be reserved only for breakthrough pain if these aren't sufficient.
And for more painful procedures, like thoracic surgery.
Right. Major thoracic procedures, like a lobectomy via VATS, are inherently more painful due to rib spreading and pleural irritation. These patients often require more robust initial pain relief, typically using patient-controlled analgesia, PCA pumps, delivering opiates, ideally combined with regional techniques like intercostal or paravertebral nerve blocks placed by the anesthetist. This multimodal approach provides better pain control, reduces total opiate consumption, and facilitates earlier mobilization.
And that recovery really is fast, isn't it? When can patients typically start eating and getting up and about?
Almost immediately in many cases. Because there's less bowel handling and inflammation compared to open surgery, significant ileus is much less common, except perhaps after major bowel resections. So patients can typically resume drinking clear fluids within a few hours post-op and progress to light meals, often within 4 to 6 hours.
And mobility.
Crucially, they're encouraged to mobilize very early, often getting out of bed to use the toilet as soon as they're awake from anesthesia. Movement is remarkably less painful compared to having a large open wound. And this active early mobility is key to reducing the incidence of postoperative chest infections and DVTs. Discharge from hospital is then based purely on achieving clinical recovery indicators. Being comfortable on simple analgesia, passing urine satisfactorily, and tolerating oral diet without nausea. Some protocols even allow for safe 23-hour overnight stays for procedures that used to require a week in hospital.
Amazing progress. Okay, let's look forward now. What's on the cutting edge? The immediate future seems to involve more integration of augmented reality, or AR.
Right. AR is essentially where you fuse computer-generated images or data with the real surgical environment, overlaying information directly onto the surgeon's view. It can help compensate for that lack of digital palpation or provide navigational guidance. It's like having a live interactive map superimposed on the patient's anatomy.
And indocyanine green fluorescence, ICG, is probably the most common, almost elementary use of AR that's becoming pretty standard now.
ICG is a fantastic example, yeah. It's a dye that binds to plasma proteins in the blood. When you inject it intravenously and then illuminate the surgical field with near-infrared light, the ICG fluoresces brightly, emitting light that specialized HD cameras can detect. This capability is integrated into many modern laparoscopic and robotic systems, like the Firefly mode on the Da Vinci.
What do you surgeons use ICG fluorescence for?
All sorts of things. Assessing blood supply to tissues in real time, for instance, during bowel anastomosis to ensure the joint will heal well. Identifying bile ducts during cholecystectomy to prevent injury. Mapping lymphatic drainage pathways in cancer surgery. Or even helping to localize tumors that have taken up the dye. It provides immediate, real-time visual confirmation of structures or perfusion that might otherwise be invisible or require complex dissection to confirm.
And more advanced AR involves actual navigational techniques.
Exactly. This is where you take preoperative imaging, like a detailed CT or MRI scan, create a 3D reconstruction of the patient's anatomy, and then accurately overlay that reconstruction onto the live surgical view during the operation. This gives the surgeon a live 3D roadmap inside the patient.
Like GPS for surgery.
Pretty much. Navigational bronchoscopy is a perfect example. It uses electromagnetic tracking combined with pre-op CT scans to help surgeons navigate deep into the lungs to find and biopsy very small peripheral lung nodules that would be impossible to locate otherwise. This kind of technology enables surgeons to perform both diagnosis and potentially treatment, like targeted ablation, in a single session, often within sophisticated hybrid operating theaters that combine imaging and surgical capabilities.
That leads us naturally to the biggest technological shift on the horizon, artificial intelligence, or AI. How is AI moving beyond just being a tool and starting to integrate into the actual surgical workflow?
AI's potential in surgery is vast. Initially, we're seeing it deployed for enhanced clinical decision support. Imagine AI algorithms constantly monitoring the surgical video feed, capable of warning the surgeon if their technique deviates from optimal parameters, or automatically detecting and highlighting critical structures like nerves or vessels that are at risk of injury, reducing the chance of human error.
But the more advanced concepts involve actual autonomy.
Yes. The next steps involve concepts like supervised autonomy, where the robotic system, guided by AI, might be capable of performing certain basic, repetitive surgical tasks independently, under the surgeon's watchful eye. Things like simple suturing or maybe parts of a dissection.
That still sounds a bit like science fiction, but the source material points to some quite startling preclinical examples already.
It does. The STAR robot, that smart tissue autonomous robot developed by researchers, has already demonstrated in published studies that it could perform porcine bowel anastomosis, joining two ends of bowel together, with results deemed superior in consistency and accuracy compared to experienced human surgeons performing the same task in that preclinical setting.
Wow. And AI is also enabling real-time tissue diagnosis during surgery.
Yes, through devices like the iKnife. This isn't strictly AI image recognition, but rather AI applied to interpreting complex data. The iKnife uses a technique called Ream's rapid evaporative ionization mass spectrometry. It essentially analyzes the chemical composition of the smoke, the aerosol plume, generated during standard electrosurgical dissection in real time. By comparing the metabolic profile of that smoke against a vast database, the AI can differentiate cancerous tissue from normal tissue almost instantly, guiding the surgeon's resection margins on the fly.
This whole digital future demands a complete rethink of how we train surgeons, doesn't it?
Absolutely. Surgical training is already being digitized. Simulation training, using virtual reality or sophisticated physical simulators, is now mandatory in many programs to achieve basic proficiency in MAS and robotics before ever operating on a real patient. AI integration here is huge. It can create incredibly dynamic, realistic training scenarios based on massive data sets of real operations, and crucially, it allows for objective, standardized feedback on a trainee's performance against established benchmarks.
But the paradox remains, the one we keep coming back to. How do we train the surgeon of tomorrow when they might spend most of their time using a robot, yet they still absolutely need to be masters of traditional open surgery for emergencies?
That is the fundamental challenge, the open surgery imperative. With the widespread adoption of MAS and robotics, trainees inevitably get less hands-on exposure to the large-scale, deep-field mechanics and, perhaps more importantly, the tactile feel of open surgery. It is absolutely vital that training programs find ways to ensure new surgeons maintain sufficient open surgical skills and the associated haptic knowledge that feel so they can confidently and safely convert a challenging case in an emergency without hesitation.
So the core principles don't change.
They don't. The basic principles of good surgery, meticulous case selection, achieving adequate exposure, whether via gas or retractors, hemostasis, and fundamental technical expertise remain absolutely paramount, regardless of whether you're holding a scalpel, a laparoscope, or a robotic joystick. The technology is just the interface. And if we try and connect all this back to the bigger picture, this whole shift towards MAS and now robotics and potentially AI, it's not really a technological advancement for its own sake. It's really the latest expression of a very old fundamental surgical goal.
Indeed. It really brings to mind that classic quote from Sir Berkeley Moynihan, writing way back in 1920. He said, "The cleaner and gentler the act of operation, the less the patient suffers, the smoother and quicker his convalescence, the more exquisite his healed wound." That core principle, that drive for minimal harm and faster recovery, that's what underpins all MAS development, right from Kelling's cystoscope in 1901 straight through to today's AI-assisted robots.
A timeless reminder, isn't it, that patient-centered focus must always remain central.
Absolutely. And so here's a final provocative thought for you, the learner, to maybe mull over. As the cost of these sophisticated haptic compensating technologies like ICG fluorescence, true 3D visualization, maybe even haptic feedback gloves continues to drop, and as AI potentially begins to master more basic procedural elements, how will surgical training adapt? How will we ensure that new surgeons still develop and retain that crucial, almost instinctive visceral and haptic knowledge base that their predecessors relied upon for swift, safe, emergency open conversion when the technology fails or the situation demands it? That tension, I think, between embracing digital precision and preserving human intuition and skill is going to fundamentally define surgical education for the next decade.